Good evening to everyone. Today I'll be presenting a class on idiopathic intracranial hypertension. So we will begin with a case followed by a discussion. Here is a 41-year-old female who presented to us with complaints of blurring of vision, transient loss of vision lasting for few seconds associated with postural change and history of vomiting, overlapping of images and headache for the past 3 months. She had no history of seizures, fever, tinnitus or weakness of limbs, no history of trauma or head injury. Her past ocular history was nil significant, and she was a known hypertensive and hypercholesteremia on treatment. Her menstrual history were regular. On physical examination, she was obese in build with a BMI of 27. She had no evidence of pallor, icterus, cyanosis, clubbing or lymphadenopathy. Her blood pressure was 150/70 mm mercury, and her systemic examination was normal. On ophthalmic examination, she had a best-corrected visual acuity of 6/6 in both eyes with intact color vision, and on checking the extraocular movement, she had mild abduction limitation in both the eyes. Rest of the anterior segments were well within normal limits. On fundus examination, she had disc edema, swollen with elevated margins in both eyes, left more than the right, and the left disc showing some peripapillary hemorrhages. Her peripheral retinal vessels and macula was normal. So, summarizing the case, here was a 41-year-old female who's a known case of hypertensive and hypercholesteremia on treatment, who presented to us with transient blurring of vision, diplopia and headache. She had 6/6 best-corrected visual acuity in both her eyes with intact color vision and mild abduction deficit. Her fundus showed disc edema with swollen, elevated margins and peripapillary hemorrhages. We came up with a provisional diagnosis of either malignant hypertension, idiopathic intracranial hypertension, or an intracranial space-occupying lesion. We went ahead and performed visual fields, and on Humphrey Visual Field 30-2, she had bilateral enlarged blind spots in both the eyes. Her ultrasound showed subtle optic nerve head elevation with no evidence of optic nerve head drusen or any other abnormalities. Coming to the discussion, benign intracranial hypertension, idiopathic intracranial hypertension, pseudotumor cerebri syndrome, is it the same thing? These names were interchangeably used in the past, but now benign intracranial hypertension is no longer used as patients don't really have benign outcomes of this disease. And now commonly used are these two nomenclature, where idiopathic is due to the idiopathic nature of the disease and pseudocerebri syndrome includes the possible secondary causes of the IIH. IIH is defined as an increased intracranial pressure due to a CSF opening pressure of more than 25 centimeter water with papilloedema and normal radiological findings in the absence of an identifiable causal factor. It can be classified as primary or secondary IH, primary being idiopathic and secondary due to any medical conditions, drugs or cerebral venous abnormalities. It is determined by the modified Dandy's criteria, which includes symptoms of raised ICP, normal neurological examination with exception of sixth nerve palsy, normal brain scan, raised lumbar puncture opening pressure with normal CSF analysis, and patient should be awake and alert. The risk factors for IIH include women in the age group of 15 to 60 years with a median age being 30 years. Obesity has a higher link to IIH, even those with recent history of recent weight gain. And medications such as growth hormones, tetracycline antibiotics, vitamin A derivatives, antithyroid medications, and abiraterone, and systemic illness such as Addison's disease, obstructive sleep apnea, severe anemia, SLE, Behçet's, PCOS, renal failure have been linked to IIH. Genetics have been seen in some patients, but studies are still underway for this. Coming to the brief pathophysiology of IIH, we know CSF is produced by the choroid plexus at a rate of around 500 ml per day. It then goes and is reabsorbed by the arachnoid villi in the dural venous sinuses. A chunk of it is also absorbed by the lymphatic circulation. So when there is an increased CSF production or a decreased CSF absorption, there results in accumulation of CSF, which leads to increased intracranial pressure. This accumulation of CSF in the subarachnoid space is continuous with the CSF around the optic nerve. So when there is an accumulation of CSF around the optic nerve, there occurs an axoplasmic stasis leading to the papilloedema. Coming to the IIH point of view, some hypothesis of why obesity causes IIH is due to maybe hormonal imbalance or inflammatory mediatory changes. It can be in the form of any dysregulation of the sodium channels in the choroid plexus, or any inflammation or fibrosis of the arachnoid villi. All these are just hypotheses, and there hasn't been an exact reason as to why obesity causes IIH. Coming to the symptoms of IH, starting with the most common symptom, which is headache. It can be positional with nocturnal awakening, which is worse on waking up. The reason for this headache is when there is a raised intracranial pressure, there's stretching of dura mater or compression of pain receptors on the vessels, leading to headache. Then there is transient visual obscurations, which is transient loss of vision lasting for less than 30 seconds. It is usually provocated by change in posture or eye movement.
Okay. How do you explain this change in posture, eye movement? What happens? Why is there an TVL? Why do they have to have a certain posture? What is the reason for TVLs in papilledema? One is, there's a transient microischemia of the optic nerves which recovers because the vessels on the optic nerve head are so engorged. Okay, microinfarction can take place. That is one thing. Other thing is mechanical compression of the tortuous nerves. Okay. Okay. So what and all causes? How is vision affected in disc edema or papilledema? Forget about diplopia and all. The visual acuity, the visual fields. How are they affected? What is the reason behind it being affected? Have you ever thought? See, it's not because swelling is there. What exactly happens? There's so much of fluid in the optic nerve sheath that causes compression. But the fluid is pushed to the optic nerve head that causes elevation of the peripapillary RNFL. So wherever that is stretched, that particular peripapillary RNFL is stretched, okay, that corresponds to the enlarged blind spot. So that is the reason why you have an EBS. Second thing, there is an acquired hypertropia. So there is a hyperopic shift. That is why there can be refractive change. How do you explain the peripheral visual defects in IIH? Have you come across case of optic neuritis in the OPD? How are the visual fields in optic neuritis? What is the most common visual field defect in optic neuritis? Is the visual loss severe in optic neuritis or papilledema? Neuritis. Why? The disc edema is not that gross in optic neuritis when compared to papilledema. But the vision loss is quite severe in optic neuritis. Why? You will find out all these answers, okay? I'm not telling.
Other visual complaints include decreased acuity, visual field changes, the most common being enlarged blind spot, and dyschromatopsia. Coming to pulsatile tinnitus, the cause of this is because the blood is being forced through a narrow portion of a compressed venous sinus. It is usually unilateral. This is one of the conditions in ophthalmology that can be auscultated as a bruit. And an interesting point is that a simple maneuver in clinic can stop it temporarily in some patients, which is compression of the ipsilateral jugular vein.
This is quite interesting, but we usually do not do this in our clinic. Not many people present with history of bruit. It's more like what complaint they say is the blockage of ear or ringing sensation, what commonly we come across.
Diplopia. The most common cause of diplopia is due to the sixth nerve palsy. The reason for diplopia is that sixth nerve palsy makes a sharp 90-degree turn over the apex of temporal bone, which makes it an easy location for it to be compressed when the ICP is raised. Other palsies that can be encountered rarely cranial nerve 3, 4, 5, and 7. Other symptoms that can occur in IH can be nausea, vomiting, radiating neck, or back pain. Coming to the signs of IH, the classic hallmark sign of IH is papilloedema, which is graded through the Friesen scale. So Friesen scale includes grade 1 to grade 5. Other changes that can be seen in the disc and the fundus, the earliest sign being absence of spontaneous venous pulsation, which is seen in around 20% of the patients. Then there can be obscuration of more than one major blood vessels leaving the disc. The retinal veins can be engorged and tortuous. Pattern lines can be seen, which are circumferential radial tension lines. Hemorrhages and hard exudates can occur, also in the form of a macular star, and at times optociliary shunts can be seen.
Okay, so patent lines are what you see in acute disc edema. Okay, when it's resolving in chronic papilloedema, whatever fold you see, those are watermarks. Okay, so apart from, why do you have hemorrhages and all over the disc? That causes vasodilatation. The capillary is really weak. Okay, and thing is that apart from the optic nerve involvement, if the edema is severe enough, it can cause retinal folds, hard exudates of the macula. All this can also contribute to the visual field defects or decreased visual disturbances. When do you have optociliary shunts? Is it an acute or chronic? Okay, from optociliary shunts are between what and what? Why do they have to occur? Where else you can come across optociliary shunts in a neuroophthalmic condition? Are they new vessels? What are they? You proceed. Let them think.
New vessels, ma'am.
New vessels?
Yes, ma'am.
No.
New vessels are different. Seen in CRVO.
No, I'm talking about papilledema. In CRV, of course, there is because there is extensive ischemia. As a compensatory mechanism, you will have new vessels. But in papilledema, the existing vessels become more prominent in the background of a pale disc or pallid disc edema. Okay. In optociliary shunts, they are not new vessels.
The differential diagnosis of IH can include malignant hypertension, which also has bilateral disc swelling, but along with peripheral retina changes such as hard exudate, exaggerated papilloedema, multiple hemorrhages, and patient can produce acutely with increased blood pressure and vision loss. Next differential is optic nerve head drusense, which is a form of a pseudo disc swelling. So here we can see bilateral swelling which showed buried drusense in both the eyes, giving a false appearance of swollen elevated margins. So here OCT and ultrasound can be done.
Before OCT, you just show them the vessels are not obscure. They are very well. You can trace them.
Yes.
The disc margin is elevated, but the vessels you can trace them comfortably. So
Yes.
there is no obscuration of vessels. But still, when you look at them, you can think that there is disc edema. Okay? Or again, correlate with the vision, color vision, pupillary reaction, and of course, the clinical symptoms.
And of course, intracranial space occupying lesions, which can also give rise to bilateral disc swelling, but with associated symptoms such as headache, seizures, and focal localizing signs.
Okay, if there is intracranial space occupying lesion, there's disc edema only in one eye, and optic atrophy in other eye. What is that condition called as? Okay. Can you explain the mechanism why it is like that? Which kind of tumors causes Poster-Kennedy syndrome? Okay, why does cause optic atrophy in one eye and disc edema in the other eye? Why? The side of swell. The site of optic atrophy is the site of the lesion that causes compressive optic nerve, which is as it enlarges, okay, and it enlarges good enough to cause a raised ICT or causing compression of the ventricles, then it causes disc edema in the other eye. What is pseudofoster? In ischemic optic neuropathies. Okay.
Coming to the investigations in IH, fields can be done which commonly shows enlarged blind spots, nasal wedge defects, and in severe vision loss, constricted fields.
Okay, can anybody explain why they have nasal wedge defects? RNFL thickness increase all over.
Ma'am, there is absence of nerve fibers on the nasal side of the retina, nasal sector.
Absence of nerve fibers? No. It's simple. Your temporal fibers are affected more. It's causing nasal defects.
Oh,
It's as simple as that.
temporal fiber.
Okay?
Sorry.
Yeah. Carry on.
Coming to the ultrasound, ultrasound can be done to assess the thickness of the optic nerve, which is averaged of about 3.8 mm. The crescent sign can be seen, which is an echolucent circle within the optic nerve sheath. This is usually seen in chronic edema. And a 30 degrees test can also be performed. A 30 degrees test is when a probe is applied in the ortho position and when asked the patient to look at around 30 degrees. So this is compared, the thickness of the optic nerve sheath diameter is compared in both these positions, and a decrease in the diameter by around 15% is a positive test on the 30 degrees probe test. The reason for this is when there is a position change, there is also shift in the buildup of shift in the change of the CSF fluid, which causes the change in the subsequent optic nerve sheath diameter.
Yeah. Anjori, the 30 degree test, is it A scan or B scan? No, the 30 degree test, is it? Read up.
An optic nerve head drusense can also be made out in the ultrasounds in case of pseudo-disc
So
edemas.
this is the role of ultrasound in parallel disc edema. In papilledema. For the crescent sign, 30 degree test, which you do not know, but you all must know for exam purpose, and also to pick up an associated drusense.
OCT is done to quantify and measure the RNFL thickness in view of disc edema and to assess the GCC for an indicator of any early optic nerve atrophy and predict the patient's prognosis. It can also be used to monitor treatment and response to therapy by assessing the RNFL thickness reduction and GCC thickness, whether it's thinning or it's maintaining the thickness. The gold standard diagnosis is the lumbar puncture, where more than 25 centimeter of water is indicator of increased ICP. It's done in lateral decubitus position, and it's very important to perform MRI before the lumbar puncture in order to rule out any mass, hydrocephalus or meningeal lesion to prevent any secondary herniation. And classical signs of IH.
So this CSF opening pressure, that is called a CSF opening pressure. As soon as they insert the needle, they have a manometer attached. That pressure is what is documented. Okay, but usually thereafter, the CSF opening pressure can fluctuate. Okay, sometimes if the patient has symptoms of ICT, but if the opening pressure is relatively within the normal but higher range, you should not rule out. You still consider IIH only. All right. Other thing is, children have the same CSF opening pressure. They do have the same opening pressure, but why it is high, we'll come across that. Okay.
And classic signs of IH seen in MRI and MRV include enlarged optic nerve sheaths due to the CSF accumulation around the optic nerve, an empty sella sign. This is because the increased ICP will compress the pituitary gland in the sella, leading to an empty sella sign. The globes can be flattened posteriorly, and at times there can be narrowing of the distal transverse venous sinus. Coming to the treatment, the mainstay of treatment is carbonic anhydrase inhibitors, where acetazolamide can be prescribed up to 500 mg TDS up to 4 weeks. In patients who do not tolerate acetazolamide, furosemide or topiramate can be given. And for symptomatic management for headache, over-the-counter drugs or amitriptyline and topiramate can be prescribed. And in cases of diplopia, occlusion and prism therapy can be performed. Lifestyle modification through diet, and physical exercises, and treatment of OSA if the patient has it. And when do we follow up these patients? Initially, monthly, once we follow these patients, and every 4 months for a year. And in this, we also perform fields and OCT to assess the GCC and RNFL thickness.
This is not a set protocol. It varies from patient to patient. Okay.
And if patients do not respond to medical treatment, we go on to the surgical treatment. The surgical treatment can include...
Amirtha, when do you classify the patient is not responding to medical treatment?
Ma'am, when the patient is still symptomatic, patient can still have abduction limitation or headache or increased ICT.
No. Once you do the LP, those symptoms will come down. Okay, yeah, but headache can worsen, but the progressive vision loss.
Visual loss.
That's what the most important criteria you need to take in. Okay, or persisting headache, though of lesser severity. That's when you consider surgical options.
Yes.
Okay, or to start off itself, there has been extensive vision loss. Patient extensively symptomatic. You consider the surgical treatment. I mean, not all, few of these.
Yeah.
See, Diamox up to 2 grams can be given. Okay, in divided doses. That must be, okay, here we give only 1000 grams per day. That's a safer dose because otherwise the patient can develop side effects. Tingling sensation, nausea, vomiting, all this stuff. So you start with, 4 times 250 milligram QID. That's 1000 grams per day. See how they're tolerating. If they're responding very well, maintain them on that particular dose. And as the symptoms are getting better and the visual acuity, everything is improving, the neurologist and the ophthalmologist, both together, we decide when to taper down the medicines. Okay. So if the patient is not, and to start off to have a good response, is give him IV mannitol. That itself reduces cerebral pressure to some extent. Okay. If they're not responding very well to or not tolerating Diamox, that is when they try topiramate, okay, and furosemide. The other drugs which can be considered. No. First give Diamox. If the headache, sometimes like what are the neurologists practice here? If the headache is very severe, they do also give topiramate. But it's only one cerebral anti-edema drug at a point of time. Occasionally they may add topiramate. Because topiramate works very well for headache part of it.
Optic nerve sheath fenestration is a common procedure done in patients with progressive loss in visual acuity. So here a slit-like space is made through the dura mater into the CSF space where the CSF is drained out, relieving the edema. This is done through a medial conjunctival approach, and it's usually done on the eye that has a worse vision first. The other methods tried are the shunts, which include the lumboperitoneal shunt and the ventriculoperitoneal shunt. Lumboperitoneal shunt is preferred over the ventriculoperitoneal shunt, as in IIH, the ventricles are almost slit-shaped due to the compression.
Or they can be normal. These are called CSF diversion procedures. Okay. The other procedure, what can be done in raised ICT is venous sinus stenting. At times, whenever there is raised ICT, the pressure in the cerebral venous can be variable at different points. Okay, so if there is the raised ICT itself can cause focal narrowing of the venous, and if the pressure gradient is more than 8, okay, that time they do consider a stent. That's another thing. What is done.
Ma'am, DAP ma'am has a question. As an ophthalmologist, what would you be cautious about giving topiramate?
What is it?
Ma'am, it can precipitate angle closure in patients.
It does not precipitate, it causes.
Causes angle closure.
How will you, how will you manage angle closure attack because of topiramate? What is the test you will do and what is the treatment? Okay, you should do a UBM because topiramate can cause choroidal effusion. And the treatment is Predfort eye drops and stopping topiramate. Okay?
Coming to fulminant IIH, this presents as extreme papilloedema, also
seen in Amirtha. So she's done with IIH. We went through what is the definition, the pathophysiology, the signs, the symptoms, okay, investigations, the treatment. Now she's just talking about the variant form of IIH. One is fulminant IIH. Okay.
Fulminant IH also presents with extreme papilloedema, also seen in typically young and obese women. These patients have rapid worsening of vision over days, and prompt treatment is required. Usually includes medical measures temporarily until surgical interventions can be performed.
So it is basically just like a typical IIH, but then it worsens very rapidly. It gives you very small window to act and treat. It usually results in permanent and extensive vision loss. And again, the disc edema, the CS opening pressure need not be way too high or way too dramatic. Okay, with an average raised ICT can still cause fulminant papilloedema, just that you have very less time to treat and intervene because the progression is very fast. How will you identify these patients? From the time they present with the clinical symptoms and you already find the visual acuity is very less, visual fields are already constricted. That is when you really need to act fast. Okay.
Coming to another variant of IH, IH in pediatric patients, it presents a little differently from adult IH. It's reported to present as early as 3 years of age.
Actually, it can be neonatal also. And more common in infants also can present with IIH.
In prepubescent children, there is no gender or obesity predilection, but in postpubescent children, it follows the trend of the adult IH, where it's more common in female and obese patients. And lumbar opening, an important point to note in pediatric IH is lumbar opening pressure is taken as 28 centimeter water rather than 25.
Why? That is because in children we have to do under sedation. Okay, when sedation, it causes hyperbaric condition that causes increased venous dilatation that results in raised ICT. That is why the the lower mark for children with sedation has to be 28 centimeters of water. But the child is lean and no sedation is given, the opening pressure has to be considered 25 only. Okay.
I would like to end my presentation with an interesting study I found about IIH connecting with cognitive dysfunction in patients. So here they assessed patients and age matched and gender matched with controls and tested attention, working memory, executive function and short-term memory. They found that attention and executive function was markedly reduced in patients with IIH, and which improved with lumbar puncture and over chronic treatment. And this interestingly impaired their attention in performing the visual feats, leading to a false positive and negative incidence. So it's also an important symptom of IH where cognitive dysfunction should be looked at. Thank you.
Very nice presentation, Amirtha. Good.